recently, Brian Thompson, the CEO of United Healthcare, has been killed. And most people believe this was an activist hit, that people are dissatisfied with health insurance in general and United Healthcare in particular. I want to look at how United Healthcare affects people with multiple sclerosis. I'll take a look at their formulary and comments about personal experiences on social media. My name is Brandon Bieber. I'm a neurologist and MS specialist. Please note this is a potentially biased video as I'm a partner of a competing medical group. Also, I had a relative complain to me just yesterday about their medication not being covered by United Healthcare, but I'll try to keep it objective and professional. The refusal of health insurance to cover multiple sclerosis meds is a big deal. This is a small retrospective cross-sectional study of 52 people recently diagnosed with MS, and half, 50%, had prior authorization requests for their medication denied. In other words, they were not able to promptly get the medication recommended by their neurologist, at least not initially. Denials were less common with older injectable medications like Avonex or Betaseron, considered to be less efficacious and less commonly prescribed recently, and more common with oral medications and infusibles such as Tysabri and Ocrevus. Interestingly, denials were more common for people with Medicaid insurance for those outside of the United States. This is insurance for children that don't have insurance through their parents, or people who are impoverished and can't afford health insurance or don't get it through employment, for instance, those collecting Social Security income. And it was less common, only 15 out of 35, and those with for-profit commercial insurance. Denial of medication was associated with a six-fold increased risk of disease activity going forward, either relapses or new lesions on MRI. Here are the tiers of medication coverage through United Healthcare. I found this online. It's from May 2024. Links in the description below. I'm not able to verify that this is up to date or accurate, and as you'll see, what's documented in benefits may not be exactly what's happening in real life, so keep that in mind. Tier 1 would be the preferred agent, the lowest cost, highest value drug, the medication your insurer wants you to be on. Tier 2 would be middle of the road drugs, mid-range cost, and there are all kinds of different insurance plans. These could be relatively inexpensive for some people or prohibitively expensive in terms of out-of-pocket cost for others. And Tier 3 would be the highest cost drugs, the drug that your insurer would prefer you not take unless it's absolutely necessary. And E means it's excluded from coverage, although with a prior authorization, meaning the provider, such as the physician, has a discussion with the insurance company, explains why this specific drug is necessary to treat your condition, perhaps you could get it. And here are the MS medications. So the first thing that sticks out is there's only one drug that is actually Tier 1, which is generic fingolimod. This is generic of the drug Gilenya, which is Tier 3 or excluded. The actual typical dose is 0.5 milligrams, so it says E here. And generic fingolimod is a decent medicine. It's considered to be a moderately effective medication. It is superior to Avonex in a head-to-head trial, though it's not a highly effective medication. It's considered to be inferior to drugs such as Tysabri, Tyruko, or B-cell depleting agents such as Kesimpta, rituximab, Ocrevus, Briumvi, for example, and Lemtrada. And so many doctors, including myself, think that a lot of people newly diagnosed with MS should be offered the option of a highly effective agent such as Kesimpta or Mavenclad. And so if Tier 1 was the only thing that was affordable, that would be a concern to me. I can say in most scenarios, if I were newly diagnosed with multiple sclerosis, I would think generic fingolimod is a reasonable option, but maybe not the best option. Honestly, probably not the option I would personally prefer. There are two higher efficacy medications on this list. One is Mavenclad, cladribine, which is Tier 3. Presumably that would be very expensive, maybe not covered by United Healthcare. And Kesimpta is Tier 2, and I'm not sure if that would be affordable to the typical person. So if you could get this medication and were comfortable with it and it was affordable, that would be a fairly good option. To look at some of the other options, I see Avonex is Tier 2 and Plegridy is Tier 3. And these are very similar drugs. They're both beta interferon 1A. Plegridy is a once every 2-week formulation, and Avonex is a once a week formulation. Presumably, they're able to get Avonex cheaper because it's an older medication, so they want you to take that instead, but they're equally effective, so that's fairly reasonable. One thing that's surprising to me is the pill Bafiertam Tier 2. This is monomethyl fumarate, very similar to the drug Tecfidera dimethyl fumarate, which is actually generic. You would think that would be cheaper for the insurance company, and that would be the preferred agent, generic Tecfidera. You can see beta seron is T2. This is beta interferon 1B, a high dose beta interferon, high frequency interferon. It's actually identical to the formulation Xtavia, literally the exact same molecule. At one point, they were made in the same factory, so it makes sense for them to only cover one of them. It doesn't make sense for them to offer both of them. It's also somewhat similar to the medication Rebif. Rebif is beta interferon 1A subcutaneous given 3 days weekly versus beta seron, which is every other day, which is beta interferon 1B. So they're very similar medications. Again, it makes sense that beta seron and Rebif are so similar, you should really only cover one of them. The other thing I notice is Copaxone and Glatopa, the biosimilar formulation of glatiramer acetate. Copaxone is the original formulation, and Glatopa is very similar, so insurance says, we want you to take the biosimilar formulation, presumably so they can save money. Now, Mayzent is very similar to Gilenya. They're both in the class of medications, S1P receptor modulators. The main difference is that with Mayzent, you may not have to do a first dose observation because of this effect where Gilenya can make your heart rate lower. That's usually a minor issue, but for some people that don't have access to a place where that first dose observation could be done, could be an issue. Also, Mayzent has a specific indication for secondary progressive multiple sclerosis, where Gilenya does not, although they're very similar medications, and Mayzent was only marginally effective in the randomized trial for secondary progressive multiple sclerosis. Let's take a look at a few studies for some of the individual agents. This is a study comparing Copaxone and Glatopa, two formulations of glatiramer acetate. Copaxone is the original branded formulation. Glatopa is one of the biosimilars. This drug has amino acids that are abundant in myelin basic protein. The drug is thought to work like an allergy shot, tolerizing your immune system to myelin so it doesn't attack. And you can see the composition of amino acids, alanine, lysine, glutamate, and tyrosine, is virtually identical between the two drugs. Also, there's an observational study looking at people actually taking these medications, and the relapse rate was lower, 0.12 per year with Glatopa compared to 0.3 with Copaxone. They thought maybe it was because people were more compliant with Glatopa because it was less expensive, but certainly Glatopa is a viable alternative. What about generic Gilenya, the only tier 1 formulary agent? This is a study comparing branded Gilenya versus one of the generic formulations. There are several. This is a simple small molecule, presumably relatively easy to manufacture, and you can see after receiving a dose of either, the concentration of fingolimod is identical in the blood. However, there have been some complaints of generic Gilenya. This is one observational study, 27 participants, and 4 had relapses after changing from Gilenya to generic. 3 had elevated liver function test, and 1 had elevated amylase, an enzyme elevated in pancreas injury, and 12 out of 27 had an increase in EDSS, a measure of disability. This is terrible, probably much worse than would be expected with placebo. I personally haven't had a problem with the efficacy of generic Gilenya, but I believe I had one patient develop a rash after changing to Gilenya, presumably because of one of the inactive ingredients. So my personal opinion is high-efficacy disease-modifying therapies should be available to people with MS at low cost, so it's disappointing none of these agents are tier 1, though some of the formulary decisions of United Healthcare are reasonable and evidence-based. You may have noticed many MS meds aren't listed here. What about Ocrevus? Well, here's what they say. It is approved as an initial therapy for those specifically diagnosed with primary progressive multiple sclerosis. That's the minority minority of people with MS because it has that on the label based on the results of the oratorial trial. In my opinion, secondary progressive multiple sclerosis is the same disease. There's very strong, in my opinion, unequivocal evidence in favor of that claim, but you may not be able to get it approved from United Healthcare. Also, it's approved for continuation of therapy, presumably because you got it with a different insurance company, if there's documented response that it has been effective, though it may be limited to get this drug for many people with MS, especially newly diagnosed people with relapsing MS. What about Tysabri, another high efficacy drug? Well, here online they basically copy pasted the product label. It's unclear to me if it's covered or not. Let's take a look at the response on social media. Here's the heralded Dominic from the msguide.com. He says, Tier 3 is the lowest overall value. Extraordinary. Treat early and effectively, and surely the person will have fewer and less complex, read expensive needs in the future. I agree. Treating disease early and preventing disability will prevent problems later on, including hospitalization, need for physical therapy, unemployment, disability, etc. Jared Simon says, never had an issue for my father with United Healthcare for prescriptions for Tysabri or rituximab or 3 Tesla MRIs or IVIG in-home treatments, never had a denial or need pre-authorization. However, he goes on to clarify that his father did take Copaxone and failed it, so the question, could you get Tysabri or rituximab as a first-line agent, both of which would be higher efficacy drugs, whereas Copaxone is lower in efficacy. I also asked him about IVIG, which was ineffective in multiple sclerosis in a randomized trial and arguably should be denied by the insurance company, though he explains that it was due to low immunoglobulins, which makes sense that it was an appropriate treatment. Ambrose says, I've had United Healthcare since March and I'm on Kesimpta the whole time. I had issues when I switched from CVS to Accredo, but I think it was because Accredo sucks. These are pharmacies, not the insurance company. UHC hasn't denied coverage for anything yet, but I'm just waiting. I have no lesions or symptoms and no disease progression. Zipjet says that policy is a little short of criminal for most relapsing remitting MS patients. Without the more effective DMTs, they will develop increasing disability. Fingolimod is reasonable as a de-escalation once MS has been quelled for years. I gotta say, I'm impressed by the level of knowledge of people on Twitter, though some people do well on Fingolimod as a first-line agent, and perhaps criminal is a bit hyperbolic. Cardigan says, surprisingly, UHC approved my year 1 and 2 Mavenclad. Now, this was listed as Tier 3, so it's good to see that they were able to get it covered. But they denied my spine MRIs, citing they aren't medically necessary since I don't have new symptoms. My last 4 relapses have involved my spine. I personally do periodic screening MRIs of the spine, though in someone who's stable, the yield is fairly low. Some people only give 2 years of Mavenclad and only treat if the disease recurs, either with relapses or new lesions, though the observational studies suggest this does happen quite frequently. Maddie says, I was on UHC when diagnosed. It took about 3 months for them to approve my Tysabri IVs. This is a high efficacy agent that wasn't on the formulary, so apparently it was not covered for Maddie. I was rejected once or twice. In that time, I was half paralyzed and it was slowly moving across my body. So even delay in treatment, if you get unlucky, can be very harmful. A few more comments about delays. Dan Graham says, I had UHC when diagnosed. I don't know if my care team had to go through the appeal process to get Ocrevus approved because I never received any rejection notice. So it seems that he got it as a first-line agent. He doesn't say if he has primary progressive MS, but it did take about 2.5 months to begin treatment. Maud says, went from Aetna to UHC in January. Even though I was currently on Ocrevus, it took them 4 months past due to approve the next infusion. This isn't that risky as Ocrevus doesn't have a rebound effect and it's considered safe to delay treatment temporarily. This could be extremely harmful with drugs like Gilenya or Tysabri. Let's move over to Reddit. Unpronounceable says, I have United and am on Kesimpta and was on Ocrevus. These are both highly effective B-cell depleting therapies. never got step therapied or anything like that. Step therapy is when the insurance company requires you to fail a cheaper agent before moving on to a more expensive, often brand name patented medication. There have been some struggles with off-cycle MRI authorizations during a relapse, but the med and yearly MRI authorizations haven't been an issue, so they report a good experience. Phantom says, I was on United when I was diagnosed last year and had no issues. They didn't give any issues with my medication, even though when my company switched to Cigna, Cigna tried to make me fail 2 other meds before they wanted to approve it. Thankfully, my doctor appealed and we won. So Phantom suggests there was more of a problem with Sigma than UHC, and it seems they're on Zeposia, which was a tier 2 agent. Callisti says, 13 years diagnosed, all with United, never had a single issue with meds, lab work, cognitive therapy, MRIs, or doctors, prior auths, etc. That being said, no matter what insurance company provides and administers your coverage plan that your employer chose, be extremely well versed in your plan. You may want to pull a copy of your current benefits so you can compare to your new, and make sure your neuro and PCP are in network to United. Sounds like good advice, although it's hard to know what specific medications they were on. Maybe they had failed lower efficacy medications in the past and already had the documentation necessary to get the medications they needed. NJ says, as far as office visits, blood work, and MRIs, no issues, but my Tysabri is not covered. This could be a huge problem because Tysabri is very expensive, nearly $100,000 per year. Sometimes pharmaceutical companies will provide copay assistance, but if the insurance company isn't covering it at all, I'm not sure they could help you. And some people get trapped in between. They're sort of middle class. They do have an income, can't get support from pharmaceutical companies, and can't get coverage from their insurance company, and they simply can't get the medication. ETA 2020 says, no issues on my end. Am on United Healthcare and went straight to Ocrevus. This is a good sign, a 31-year-old who probably does not have primary progressive MS being able to get a high efficacy drug like Ocrevus as a first-line agent. My neurology clinic handled all the prior authorization with insurance and funding from Genentech for my infusion and treatment costs. Would this be available to everyone or only in their specific circumstance? Fish says, United was okay. It's not great, but okay. It was a slow process, but once set up, it went fine. I had 3 versions of UHC for about 7 years. You have to follow up a lot, lots of resubmits, and more info. So huge hassle, like many people complain about. They required failing 2 DMTs before high efficacy at my age. So that's a red flag to me. There is less evidence for medications for multiple sclerosis in people who are older, but that's not different between high efficacy and low efficacy medications. So there's not a reason to specifically prefer a lower efficacy medication unless you're concerned about risk, like someone has a higher risk of infections. And if someone is failing medication by having relapses or new MRI lesions, a lot of people would offer high efficacy medication regardless of age. So it's hard to know the specific circumstance here. Dimethyl fumarate has been fine for my needs, no lesions for 3 years. This is Tecfidera, which is not a high efficacy medication. So hard to know what's going on here, but a little bit concerning to me that someone would have to fail 2 disease-modifying therapies before having the option for a stronger treatment. Little Miss DLG says, my old job had United Healthcare. I mentioned it before. They had grief over an MRI. There was a back and forth letter with my doctor wanting to know why I needed the MRI. They also didn't want to cover Aubagio. So Aubagio is a once-a-day pill, a lower efficacy medication, but eventually did. I don't know why it was an issue when I was on it previously. So they didn't cover continuing therapy. My new employer is BCPS, and they have been decent. So certainly she's had her struggles. And I read many other comments on social media. I don't have time for them all. Some were positive, some were negative. Certainly frustrations symptoms or being denied medication recommended by your neurologist was very common, though it's not 100% clear to me that this is more common with United Healthcare. People had the same frustrations with other forms of American health insurance. I'd be interested to know your experiences if you had United Healthcare and other American health insurance coverage. What were the differences? Please share in the comments below. Or if you have multiple sclerosis in a foreign country, what are your experiences? And does anyone have suggestions to improve the American healthcare system? My concerns about United Healthcare would be the formulary. I don't like the lack of high efficacy agents as tier 1 on the formulary, particularly for people with newly diagnosed relapsing MS, because the high efficacy medications can be extraordinarily beneficial and life-changing for many people in that situation. And I really don't believe in step therapy, the idea of failing medication to get on a stronger medication because you could acquire irreversible neurological disability. And there's just increasing evidence that stronger medications early on are the way to go for many, not all people with MS, of course, if you're willing to risk the side effects. I should also note that other countries have problems with healthcare too. I know in the United Kingdom at one point, I don't know if this is true any longer, in order for people with MS to get the drug Tysabri, they had to have 2 disabling relapses while on a lower efficacy agent and could potentially acquire permanent neurological disability while qualifying for this medication. And I don't think that's the right way to go, though it does potentially save money in the short run. So it's not specific to the United States. I don't know if the policy has changed since then. Finally, I want to say very clearly that assassinating a healthcare CEO, even if you find their practices to be distasteful, isn't going to help anyone. Instead, you should vote. Vote with your mouth and your keyboard. Communicate your ideas to other people. Vote with your ballot. Elect the candidates you think have the best ideas about healthcare, and most importantly, vote with your feet. If you have a choice, go get the health insurance you think is best amongst the available options. And if you're up for the challenge, pursue a career in healthcare administration. Not as easy as it looks and not for the faint of heart, but I know some people who do it and they're very talented and hardworking, and they help a lot of people indirectly and they don't get much credit at all.